Hello, I'm Dr. Leslie Citrom, Clinical Professor of Psychiatry and Behavioral Sciences at New York Medical College in Valhalla, New York. Welcome to this program titled Navigating Schizophrenia Part 3, the role of long-acting injectable antipsychotics in the treatment journey, a patient perspective. This program is supported by an independent educational grant from Janssen Pharmaceuticals. Joining me today is Mr. Max Gutman, a patient advocate from Yonkers in New York. Welcome, Max.
Thank you. Thank you. Thank you.
It's great working with you again, and I'm looking forward to your input on what's important to people with schizophrenia regarding long-acting injectable antipsychotics. Now, there's some challenges that patients face in early or first episode psychosis, and some of these include the hospitalizations that may be more frequent, particularly as we'll discuss when medications are not adhered to. Patients are new to treatment and have to adjust to this, and this may be quite challenging. At the same time, attempts are being made to find the right medication and the right dose. And then in the end, patients may feel that they're better after the first episode. The thought that one and done enters one's mind, and there may be a hesitancy to accept the illness and the need for medication. There may be actually side effects and feeling that they're not themselves. So this is quite a challenge. So we're going to look for balancing the highest efficacy with a very favorable side effect profile, at least we'll attempt to, and particularly in patients in early or first episode psychosis who are more sensitive to side effects. And Max, what kind of side effects were you experiencing?
Well, I was tired. I was tired a lot of the time, and I've been putting on weight for quite some time now since I had first been on an LAI. So weight gain, some lethargy, but very stable. So it's a hard trade-off.
It is. Others discontinue medication, and up to 44% discontinued in the first year after their first episode. And when we look at adherence in general, I'm sure you found this in your own work with people with schizophrenia yourself, as a patient advocate, that up to two-thirds of people are at least partially non-adherent to oral medications in the long haul, and up to half almost stop their oral medicines. And of course, this has implications for symptom control and ultimately going back into the hospital. So this is a challenge. How we ask will actually determine what we hear. So if I just say, well, you're taking your medicines, right? The usual answer is, of course I am. Why wouldn't I be? So there's some other ways of asking about medicines. And what I like to do is first normalize the adherence struggles by saying, with any illness, it's often challenging to remember to take a medicine every day. And this is true not only for schizophrenia, but also for asthma and hypertension and you name it, diabetes. It's hard. And so we need to develop some ways of reminding ourselves to have a routine. So some questions to address is figuring out what is the routine that individual has when they usually take their medicine, what reminds people to take medicine. And then I always ask about, well, exactly how much do you take when it's time to take your medicine? And sometimes I get surprising answers, like I felt better, so I only took half, or I felt worse, so I took double. And there was one person I remember who told me that they've been taking half the dose for the past several months in order to save money. So you hear all sorts of things when you actually ask about the behaviors, but also the attitudes are important. What do you think you're benefiting from the medicine? And have you ever decided not to take your medicine on purpose, and what led to that? So, Max, was your prescriber asking you what you were perceiving as benefits?
Well, when I was in the hospital, that's when I was first offered the LAI, and I was inconsistent with medication beforehand, and that's what led me to become hospitalized. But I always find that saying, "What is the medication helping you with?" to be, a little bit of a better angle into talking about adherence, because you want to know if it's helping and what it's helping with. And that's good inroads to talking about, offering other solutions and other options.
Yeah, sometimes we think too much in terms of symptoms, and people don't come for treatment for their symptoms. They don't come to have their positive negative syndrome scale score reduced. They're coming for help with their life and achieving what they want, a job, a home, relationships. And so having linkage between the medication and achieving life's goals is key to having a conversation that's actually productive. So this is part of the story that we have to engage in with people with schizophrenia in terms of what are people looking for in terms of treatment. Ultimately, we're also going to have to think of practical issues like how do you get your refills? And do you feel that your questions are getting answered? So that's pretty important too. Now, Max, you were lucky in terms of being introduced to long-acting injectables early on in your disease, and this is actually a state of the art. Earlier use of long-acting injectables can decrease the time that people spend experiencing psychotic symptoms, in particularly the early stage of the illness. And in the first 2 years, experiencing psychotic symptoms is the strongest predictor of long-term symptoms and disability. Ultimately, we can decrease the number of psychotic episodes with guaranteed delivery of a medication. And I can't help but remember when I worked for the New York State Office of Mental Health and I worked in a state hospital unit, that I was dealing with patients who were 50 years old, who've been ill for 30 years. And only if they had received medicines more consistently when they were 20, they would not have ended up in the state hospital system. We know that patients experience a decrease in treatment response with every exacerbation. And this is probably due to neuropathological brain changes that progress with each clinical episode. Long-acting injectables help address this issue of making sure you have guaranteed delivery, but it also has something else going for it, and that is we know that someone is taking medication. So if someone is not doing well, we can look for other reasons. Maybe a psychosocial stressor, maybe the resumption of substance misuse or something else. And if someone is not coming for their injection, well, that's easily identifiable, and we could actually handle that. Any ideas there, Max, about other benefits?
Well, you know, it's for, in terms of being a therapist, it takes the conversation away from compliance in the therapy room. I know that when I was in a client myself, first getting out of the hospital, the question, are you on your meds? Are you taking your meds? How, any conversation really about meds was distasteful for me because I had so much to talk about. My life is in shambles, and a lot of people's lives are in pieces when first episode psychosis hits. So there's so much to do and so much to worry about. Why am I worrying about what I'm already supposed to be doing, which is taking my medication? So I think one of the benefits is keeping the priority front and center, which is the goal of the patient and what needs to get done to get there.
Yeah. So doing this early is better than doing this later, obviously. And there are benefits of long-acting injectables over oral medicines in first episode schizophrenia. I'd like to just highlight a few of the studies that were done, illustrating that relapse prevention was efficacious, reduction of hospitalizations are noted, and overall symptom improvement. This was established first off in large database studies looking at the use of LAIs in an entire country like Finland, where they actually could compare people who were given a long-acting injectable versus their oral counterpart after their first hospitalization. And the long-acting injectables were superior by a lot. And that led to other examinations of other country systems where you can actually collect this data. There's also randomized controlled trials looking in people with first episode schizophrenia and receiving an LAI versus treatment as usual, usually an oral medicine, showing also the avoidance of relapse. There's been studies that have suggested maybe Advantages are overblown, though, but those studies, sometimes you can find flaws in them. They don't necessarily reflect the real world setting of really uncertain adherence in people who are left to, go about their business despite cognitive impairment and disorganization in their thinking and uncertain housing situation and unemployment and so on. Very tough to remain on medicine under those circumstances. So there's a lot to be said for guaranteed delivery, but we can't get there unless we have a therapeutic alliance. So what is a therapeutic alliance? It's actually forming a relationship with a patient so that the patient feels cared for, understood, and that attention is being paid to their hopes and desires. So this means a number of tasks at hand. One is education in terms of making sure patients and families are knowledgeable about treatment options. For example, long-acting injectables may be completely unknown to the patient or the family. And we can talk about advantages and disadvantages for each kind of treatment, but engage that person in decision-making and development of the treatment plan. This means having a conversation about activities of daily living, socialization, quality of life, the impact of the condition on the quality of life, the sense of connection with others and ability to actually enjoy life, and looking towards medication as a tool, not for symptom control that we are measuring, but to help the patient with functional goals in life engagement. So of course, I want symptoms to be better. I want hallucinations and delusions to be less of a problem. Patients want to have better functioning and have a job, have the ability to live independently, and have a place that they can call their home. So this is very different than just symptoms. Now, there's some additional considerations that we need to consider in terms of functional recovery. The side effect profile, of course, has implications for adherence, and we need to explore, well, is that going to create a problem for that patient in this particular choice of medicine? And the values and preferences of the family and the varying degrees of education about the illness. I like to advocate for engaging families and patients in NAMI and other advocacy organizations as a way of feeling a sense of community with others and helping and learning from each other regarding what to do and what's available. Max, have you engaged with advocacy organizations? I'm sure you have. Max, I can't hear you.
No, I was saying that it's great to participate all over. You have to get your voice out there as much as possible, especially as a patient advocate who is representing people that are unheard at times. And you have to ask yourself, well, how am I going to represent myself to give the correct representation? But it's important to do that in as many places as possible and in as diverse a setting as possible. So yeah, it's a great thing. It's a great thing. It's important.
So NAMI has this education program, right? Have you participated in that?
I have not participated in the NAMI program. Submitted a whole bunch of NAMI blogs. So a lot of my writing is out there in the NAMI blog arena. But I didn't go the patient advocacy that route through NAMI because I was already telling my story. So it depending on how you sort of land in the recovery world, it could make a difference in which organizations you go through and what you speak about. I didn't want to have to go through a training on about how to speak. I was already a public speaker, but for a lot of people, it's very important and vital especially because a lot of people don't have the opportunity to go to graduate school or college and learn how to really speak as assertively as possible in front of as many people as they can. They're at home. They're boxed in. They're a victim of their own unfortunate circumstances. They don't get a chance to connect with the public. So it's really important.
Yeah. Before we get into more on the patient perspective and being an active participant in treatment selection, I want to just reiterate a couple things about long-acting injectables. They're more useful and relevant before relapses have occurred. And this sounds pretty obvious, but it is a truth that if you have a person with guaranteed delivery of an antipsychotic that prevents relapse, they're going to have fewer relapses. And this is critically important at the beginning. And this has been examined time and time again, comparing oral versus LAI use. It's, I think, a mistake to be reactive here in limited in offering LAIs. I think they should be offered routinely to everybody who is receiving an antipsychotic. Because if you can't, if you don't know they exist, then how can you express a preference for them? Guidelines have consistently said LAIs should be used, of course, for those with poor or uncertain adherence, but also for those who would prefer such a treatment. And how can you prefer such a treatment if you don't know about it? And usually my first gambit when talking about it is, how would you like to get your medicine every month or every 2 months? How does that sound to you? Well, it sounds pretty interesting. And I sure wish there was a long-acting antihypertensive, for example, would make the lives of everybody with hypertension a lot easier. But with schizophrenia, we do have that option. So, Max, tell us more about the patient perspective, being an active participant, and about an organization called Cure SE and all the rest.
Oh, sure. So, start from the very end. I encountered the Cures Foundation after publishing, I think it was my first memoir about my experience living with schizophrenia. So after writing and getting it out there, I went on, did an internet search, and I encountered the Cures Foundation, and I met Bethany, and I gave her copies of my work, and she read it, and she said, "Oh, this is a person who." She said, when she first said, "Would you consider yourself cured? Would you consider yourself recovered?" And I really think recovery is an ongoing process. I don't really think it's a terminal process, but I answered yes because I think I'm as recovered as I can be at this point, given the opportunities I've had, for treatment. But in terms of that foundation, it's been really vital in connecting me with a lot of audiences and with the public in terms of explaining what it is to live with this disorder. It's very complicated. And, as patient perspective, the patient perspective is looking at other patients. So when I was first in the hospital, the state hospital, I saw firsthand what it was like to see people relapse over and over again. Sure, I didn't watch them trickle in and out, but I remember this woman, older woman, and the attendant said she was like 30. And I said, 30? And he said, she's had a rough life. And I can only imagine the life that this person led, living, relapsing over and over again. It takes its toll on you. Anytime you have destruction and chaos in your life, it impacts you. So imagine that happening every day for years and years and years. It takes its toll. You age. So a part of being a patient advocate and getting the word out there is explaining to people that why give yourself an opportunity to fail. I wanted to always have the best possible medication, the best delivery system, and the best options for myself to succeed. That's why I've been on an LAI, and that's why I continue to believe in long-acting injectables. We have to give ourselves every possibility of success possible. And when you think back to people that keep failing out or cycling in and out of the hospital, it's avoidable. It's avoidable.
Yeah, so if we're starting out with long-acting injectable antipsychotics early on, we need to communicate that we do reduce relapse risk, and we know that every relapse makes recovery more difficult. That's important information. But there's also the convenience of lower, taking a medicine less frequently, obviously, once a month, every 2 months. There are some also that ultimately you can take twice a year. So that's a potential for guaranteed delivery over the long run. And there are some concerns, though, about the different molecules. That has to be discussed. Not everyone will respond to the same thing. I like to have patients actively participate, because I find that if the decision is being made by the patient, the likelihood of actually following through is much higher. And that goes a long way. So I need to understand what the patient's preferences and goals are. It's generally functional recovery, not symptom control per se. People want to function better, as well as minimizing problematic side effects. So this requires some education and some investment in time. It's not one and done. And did you immediately embrace long-acting injectables when first discussed?
I did. I did, because it was presented to me as an opportunity to be discharged from the state hospital a little earlier, so that I was in there long enough, I felt. But I embraced the long-acting injectable because my experience was so traumatic that I never wanted to put myself in a space where that could happen again. I mean, it was horrific. That's why I wrote a book about it. I would never want to go back to that mindset ever again. And I saw the long-acting injectable as a way to avoid that from happening. So yes, I embrace health and wellness and healthy decisions in all of my treatment planning.
So in terms of your interactions with others that you've counseled, has LAIs been embraced as readily as by you?
Yes, no. In the outpatient setting, in the private practice level, it's a little bit more difficult to sort of, it's a little bit more difficult. Usually people don't embrace that level of I need to take care of myself until they're put in a position where they need to. People that I work with are generally fairly stable. And they're not bottoming out, and they're not in crisis mode. And if you're a good therapist, you'll maintain your caseload that way. But I have had people that you start getting those strange emails, you start hearing bizarre thinking, and you know where it's headed. And I've worked with a lot of hospitals coming back out to outpatient, saying this person would benefit from being on an LAI, because I can't put them on one as a therapist. But I can work with the hospital to make sure they're on one before they come back to me.
Yeah. There's some clinician perceptions that steer people in the wrong direction. The assumption that people will refuse an LAI, or they would always want an oral medicine, or that they're taking their oral medicines well enough, or an LAI is too expensive, or should be avoided early on. And they sometimes feel that, well, they already know about LAIs, they're not asking for them. The reality is far from that. And patients will report that their doctor never informed them about LAIs. And they actually would like an LAI. So this is strange for some doctors to hear, that there's a preference for an LAI. Well, I can think of many reasons why. They prevent relapse better, and they can actually have the patient feel better support in their illness. And I'm not just making this up. This is based on patient surveys. So obviously, we have some disconnect between what some people believe about LAIs and what LAIs truly represent. So I'll present the LAI by normalizing non-adherence, as we discussed. And I'm also mindful that my patients, no matter how good I think I am, patients remain partially adherent. I mean, that's a fact of life. And it's true for all chronic illnesses. So I need to figure out why someone may be hesitant to take an LAI. Maybe it's a matter of thinking that it's painful. Maybe that it's really for those who are more far gone, so to speak, as a last resort. So I couch it in positive terms, that someone is taking control of their illness, getting families involved. They're the biggest ally in the LAI conversation. And if someone says no, then I'll bring it up later. I don't badger them about it, but I'll bring it up. You were actually much more willing when discussed because of your individual circumstances, but as you mentioned, there are others who may be hesitant at first. So there's a lot to say about the benefits. What would you say if I said, Max, look, I have this patient. I've been treating him for 5 years now. I've been bringing up this LAI business. He keeps on saying no. Can you help me out? What would be your approach?
Well, I wonder why he's in treatment for 5 years and not making progress, But no, I mean, I would frame it almost that way. Um, Being on the right delivery system with your medication, given everything that we discussed, it can accelerate your progress in treatment, a patient's progress. And a lot of the times, over 5 years or 10 years, you see diminishing returns in therapy. And I think that if a patient is doing what they need to do and they're adherent to their treatment, and they're participating in their treatment, then treatment should work and they should see progress. So, I would frame it that way, that this is a method for you to participate in your treatment a little bit more, to be perhaps experience more benefits from what we're trying to do here, because it seems that, we're not making the progress that we'd like to. And I know you'd like to see progress in your life. I know you want to go to that, you want to go to school, or, you want that relationship to work. So let's get there a little bit faster, sooner rather than later. There's one life to live, and live it as healthfully as possible. This is a way to do that.
Yeah. So you're emphasizing the efficacy and how the medicine works. What do
Sure.
you say when someone says, well, they're needles and they hurt?
Well, I've been in a lot of pain before. Maybe not from needles, but as a result of mismanaged psychosis and tremors, being scared and fearful, delusions. That's pain too. That's emotional pain. And you know what? That's pretty awful. I would take a needle once a month for a second over living in persistent, constant delusions where you're afraid that the house is going to blow up, or a bomb's going to go off, or aliens are going to come. Who knows what the delusion is? But that sort of panic, that's a lot worse, I think, than a needle or a pinprick every month or two.
Yeah, no, that's good advice. I tell patients that it's like a flu shot that they got. And in studies that have been done looking at the amount of pain someone experiences on a scale of 0 to 100, 0 meaning no pain, 100 excruciating pain, it's rated at about 5 out of 100. So that puts it into perspective. If someone has tattoos, I point them out. They hurt a lot more. If they have a history of IV drug abuse, that's much more complicated than what we're talking about. Plus, we have two kinds of injections now that can be routinely employed: in the muscle or under the skin. And so patients can try each out, and whichever one they would prefer, that's the one they should get. So I would put the patient in the driver's seat there. So in essence, it's getting that patient to be an active participant. Max, what's the last thing you want to share with our audience that you feel absolutely they should know?
Well, there are changes in insurance, there are changes in life circumstances where, it may be complicated to go to get your LAI, or it may be problematic fixing and adjusting an insurance, or maybe the timing of when you would go is changed due to a work requirement. But one thing doesn't change is your duty to your health and to take care of yourself. So whatever's going on in your life, if you don't have your health, as your first priority, none of that's going to work out. In my life, I've had a lot of changes, just like everybody else. I've gone, either starting school or starting a new job or family requirement. But one thing's for sure, I made sure that I was always putting my mental health front and center, or else none of that would work out. And, you want your life to work out in a wonderful way. So give yourself an opportunity to do that.
Yeah. Well, thanks very much, Max. I would like to also thank the audience, and please use that QR code in order to get your credit for this activity. Please connect back on the 19th of December at the same time for the final discussion on the impact of the long-acting injectables on outcomes beyond psychosis for patients with schizophrenia.